Dr. Kiara Alvarez is an instructor in the Disparities Research Unit in the Department of Medicine at Massachusetts General Hospital and Harvard Medical School. Her research and clinical work focuses on improving adolescent behavioral outcomes, behavioral health outcomes with an emphasis on Latinx and immigrant youth and their families. She has a particular interest in the prevention of suicidal behaviors, which she'll be talking about today, and the integration of behavioral health care across clinical and community settings serving youth. Dr. Alvarez is currently the principal investigator for an NIMH-funded career development award called the Early Intervention for Suicide Risk Among Immigrant Youth, which focuses on family-based strategies to prevent suicide. She's also the co-principal investigator of a William T. Grant Foundation-funded project, MHG Photo Stories, which is a mixed methods participatory research project focused on eliciting youth perspectives to inform community-based programs and reduce behavioral health disparities. Dr. Alvarez completed her psychology internship training at Children's Hospital, Boston Children's Hospital, which is part of the Harvard Medical School, and she received her PhD from the school psychology program at University of Texas, Austin, which is an excellent program. She is a fellow of the APA Minority Fellowship Program in the Mental Health and Substance Abuse Services. She also has an EDM in Human Development and Psychology from Harvard and a BA in Literature from Harvard. So please join me in welcoming Dr. Alvarez to our campus today.
All right, thank you everyone for being here today. I really appreciate you coming out to hear this presentation, and I think to let you in on a little bit of how I wanted to structure this. I'm really focusing on the process for me of developing the current research program that I have in suicide prevention, and it's really in its early stages in many ways, and so I'd like to let you into a little bit to what the reasons for what I did, what I plan to do, and also the questions that I have now, the things that I'm grappling with, and I'd love to leave a good amount of time at the end for discussion, to really hear your input and hear about ideas you have and also things that you're working on or things that you're interested in knowing more about. Before I start, it would actually be really helpful for me to know, for everybody that's here, who has research and clinical interests that are in the area of immigrant families or immigrant youth? Okay, so a lot of people, good. And how about in suicide prevention? Okay. And how about with Latinx youth specifically? Okay, great. So that really helps because it's a little bit of, I'll be bringing together background in a few different areas, but I'm really going to touch upon it somewhat briefly, so there's certainly a lot more that can be said about each of the areas, but some of it for some people will be things that they've heard before, and some might be new for others, but I'm also really happy to share resources and discuss more after if there's areas that need a little bit more attention or focus. So before I start, I want to acknowledge sort of the very large village that has helped me get to this point and supports my research now. Mentors, both present and past, and so really currently I work in the Disparities Research Unit at Massachusetts General Hospital with the chief, Dr. Margarita Heredia, who has been a great mentor to me from postdoc and beyond, and is a mentor currently on my K-23, and I have several other mentors on that project. Peter Wyman, who's in suicide prevention, Patrick Shout, who's a social psychologist, but is also a statistical methods mentor for me, Robert Roberts, who did suicide prevention work actually at the University of Texas, and John Alpert, MD, who's one of Fiore, as well as Holly Wilcox, a suicide prevention researcher that I'm currently learning from on a different grant, Lee Zayas, who did a lot of the foundational work on Latina adolescents and suicide risk, and Cindy Carlson, who is my mentor in graduate school, as well as Dr. Aurora's mentor, and who's really influenced on my training in family prevention and intervention. Some research collaborators that you'll see mentioned, some of the projects that I'm talking about, as well as a great team of research assistants that have worked with me, and then the research funding that has supported my work to date. So as I mentioned, I'll give a little bit of background, talk about what are some of the key mechanisms for immigrant youth that I'm interested in addressing for suicide prevention, the development of a preventive intervention, as well as these sort of new considerations that have come up in the course of my project, and new sort of external challenges and also opportunities, and what my current areas of inquiry or questioning are at this point. So to start with, why focus on youth suicide? So depending on where you come from, this may be a question that you already have the answer to, but for some people it's actually a little bit of, why? Why is this a problem? And so suicide is the second leading cause of death among 10 to 24-year-olds in the US. So the first cause is really injury, accidental injury, and then it's suicide right after that. So we have, just the latest numbers from the CDC in 2016, over 6,000 youth in those age groups died by suicide. A very concerning trend is really that rates have increased in every age group except the very oldest, ages 75 plus, between 1999 and 2014. And so we really see this sort of declining overall mortality in many populations. We see a decline in homicide rates that has been ongoing since the 1990s, but suicide sort of either remains flat or increases. And one of the really concerning trends that was noted in this analysis between 1999 and 2014 was that the rates for girls who historically have lower rates of completed suicide really are increasing exponentially. And so among the youngest group, 10 to I think 14, there was something like 200% and some increase in the numbers. Among the teenage girls, older teenagers, it was still a 50% increase. So we're really seeing this where this gap between girls and boys is sort of closing a little bit, and it's not because rates are going down for boys. So this is sort of the big conundrum of suicide prevention research. Why do the rates keep going up? Why is it that with everything people are doing, we're not able to get to declining rates? So per the CDC, another important piece is this huge number of youth that are treated in emergency departments. And so I think for all those that are clinicians or have been trained in any way in clinical work, it's that it's not just those numbers of deaths or even attempts, but it's really this larger impact. So it's kids that are injured and are being seen in EDs, it's kids that are in inpatient units, and so they're missing out on school, missing out on sort of their day-to-day activities. There's a lot of ways in which young people are affected, and then it's also the kids that are friends with these kids or go to school with these kids that are really also impacted. It's a really tragic experience, for anyone to go through and to be exposed to, and to think about that influence that it has on youth broadly, I think is very important when thinking about prevention. So why focus on immigrant families specifically? So one of the reasons is really just the huge numbers, right? So 25% of our population under 18 is either first generation youth, or the larger number of that is second generation. So it's kids born to at least one foreign-born parent. And so this is a huge segment of our youth population in the US that has particular considerations in how to approach mental health and prevention work. And so for me, that's a good enough reason, right? But people also wonder about, well, is this group more at risk, less at risk, and we can talk about that. Within this immigrant group, it's very diverse, as we know in the US. The largest proportion is Latinx youth, 56%, and then 22% Asian, and then, as we know, a lot of diversity within those broad categories in terms of countries and nationalities and who is coming from where. We also know that immigrant youth access mental health services at lower rates than non-immigrants. And some studies have shown this is particularly true for internalizing disorders. So kids that are depressed, kids that are anxious are going to be much less likely to get treatment than non-immigrant youth. And so that's another major reason why we need interventions that are tailored or that are really going to draw people into care. And I have some references at the bottom of the slides, but I'm also happy to share full reference list for anyone that's interested. And so that now, even further, why within the immigrant youth population focus on Latinx youth? So there's good reasons to focus, I would say, on any particular subgroup. Latinx youth for me was something where, it was the group. I'm Puerto Rican myself. I'm bilingual. It's the group that I was working with before I went to grad school in nonprofit settings, and so it made sense for me to continue focusing on this group in terms of my research. But there also are some reasons within the area of suicide disparities, and so historically, Latina adolescents, so the girls specifically, have been identified as a group that has elevated rates of attempts. So not necessarily completed suicides, but the attempts themselves, self-reported attempts, compared to white and black adolescents. Interestingly, we are seeing a change in that trend with the most recent data. We actually are finding the most recent data from 2017 for the Youth Risk Behavior Survey that black adolescents have higher rates for the first time, which is really concerning. And that's kind of another area of discussion because there's research being done in that area. But again, historically, there's been this higher risk that has been identified and this concern that we don't really have interventions to address it. And within the Latinx population, there also are immigrant generation differences. So a lot of studies will say, and this is true for youth as well as adults, that second generation are at higher risk than the first. And so if you were born in another country in Latin America and came to the US, you actually are at lower risk of developing, among adolescents, depression, suicidal ideation, suicide attempts. And so kids that were born in the US have this higher risk. We see the same pattern with adults in general, this idea that immigrants are healthier and healthier in terms of mental health than those born here. But one of the different patterns that we really see is that first generation youth that come in early childhood really look very similar to second generation youth. So it makes sense, right? Somebody migrated here, but they were under the age of 6, and they were raised here essentially as though they were born here, compared to somebody that migrated in adolescence, for example, where they really experienced a lot of the culture in the home context before moving. So there's different reasons to sort of focus on different groups and to consider what the risk factors and protective factors are for first generation versus second generation. And then I would say there's even more complexity within that, but we'll talk about that a little bit later. So given all of that, right, given suicide risk among children and adolescents, given the need to focus interventions on immigrant youth and on Latinx youth specifically, where are we, right? So when I started working on my project, I had people that told me, well, just find something that works and then adapt it. And the problem is with suicide prevention is there's almost nothing that works. There's almost nothing that we know works, I guess would be the better way to say it. And so there have been some great reviews done about interventions to really show that we don't have a lot of good long-term data. We have these sort of universal school-based prevention programs, which have been disseminated widely in many cases, and we don't necessarily have great data to show that later on in the long term they actually reduce the absolute risks of suicide in the population. We have analyses of evidence-based depression treatment that show that even though they reduce depression risks, they don't necessarily impact suicidal ideation and behavior. So this is really concerning. There's a lot of great people doing work in this area, but it's definitely behind other areas like depression and anxiety in terms of building up the evidence base. So a few years back, you can see in that second bullet point, there was a review that showed there were no, for kids that had already attempted suicide, there were no treatments that had been shown to be effective in 2 separate randomized clinical trials. There were a few that had been shown in 1. Since then, dialectical behavior therapy for adolescents has been shown now in 2 independent clinical trials that it really does reduce the risk of attempt, which is wonderful. So now we have a treatment that we can say, great, this is a strong evidence-based treatment for suicide, kids that have attempted suicide. Now, on the other hand, anyone that has been trained in or knows about dialectical behavior therapy knows it's also a very intensive treatment. It requires a lot of resources clinically because you're doing individual clinical work, you're doing group-based work, you're doing parent work. Ideally, in the kind of gold standard, you have consultation. There's a lot of things that go into it. So it's great to have for the kids that are at that higher risk and really need it, but we need more earlier in the spectrum to prevent kids from getting to that point. We have some that are really promising in the area of preventive interventions. Youth Aware of Mental Health was developed in Europe and really showed some great results in schools, and it focused on building coping skills. It needs to be replicated, and there are people working on that. And programs that increase social connections among peers. So Sources of Strength, which is evaluated by Peter Wyman, who's one of my mentors. They have a trial, and they're, hopefully we'll have some good results on that. But those are things that are being looked at and are being worked on. And so you really see that the focus of those is on those building up those protective factors. So programs that just do gatekeeper training, of just training the people around you to refer you for treatment, have some good results and sort of intermediate outcomes, but not necessarily long-term in reducing suicide rates. So we really need more that's going to build up those protective factors. And then finally, in terms of background, those key mechanisms for immigrant populations are not addressed in the existing interventions. So we have data that shows what are some of those mechanisms, how are they linked to suicide. We don't have them in the interventions. Any questions up till that point? That's a lot. Okay. So what are those key mechanisms, right? What am I talking about? So for immigrant families, there's a lot of diversity within the context of being an immigrant, right? So there are experiences related to migration that vary wildly depending on where you come from and why and when. So these are just a few examples, right? It's the reasons for leaving. Were you pushed out of where you live because the conditions are such that you can no longer live there? Or were you pulled by an opportunity somewhere else? Did you migrate purposely in order to pursue education or pursue a job opportunity? Those are 2 very different experiences. What was the journey like? Even within like a small group of recent immigrant Latino youth that I work with, there are kids that had a visa and got on a plane and arrived with their parents, and there were kids that migrated alone, going through an extremely treacherous journey to get to where they are today. So that journey can really vary and can have a very strong impact on mental health. What's the home context? Where did they leave and what were the conditions like there? And what's the context of reception? Where did they move to? Did they move to a very welcoming community that really embraced them and provided opportunities to become part of the community, or did they move somewhere that was hostile and that created a negative environment to be in? Family separations, who's been separated, who's been left behind, who has been who has been reunified with. So we have, we'll talk about that a little bit more later with kids, but kids that have experienced prolonged separations and then become reunified in adolescence, there's a lot of challenges there. What are the educational and employment experiences that people have had? And what are the changes in social status, right? So people that had a certain level of social status in a home country and then moved to the US and can no longer, for example, people that had a particular license to practice in an area and they moved to the US and they no longer can. Years ago I worked with a family where the mom had migrated from Cuba and she was an accountant in Cuba and she was a home health care worker in the US. And so what did that change mean for her in terms of her identity? What did it mean for her in terms of how she saw herself in day-to-day life? What's the frequency and quality of the contact transnationally? So is this a family that really has a lot of opportunities to stay connected to their family in other countries, or is this a situation where you really have a lot of difficulty, where you haven't seen people in many years or aren't connected closely? So that can really vary. And with technology, luckily that's something that's really improving in many ways, but not for everyone, of course, because of the conditions where you are or the access that you have. So a lot of complexity there. And then the things that we hear about a lot in the literature and that I think have been developed especially well in relation to substance use among adolescents, and so acculturation stressors. So the idea that acculturating to a new environment really increases stress, right? And so some of the areas that have been talked about for adolescents have to do with language conflict. So your language, in relation to the language that's spoken in the country of migration, experiences of discrimination, the sense that the U.S. is a closed society. So if you have a sense that the U.S. is not open to immigrants and is not allowing for opportunity, then that's a very different experience than feeling like, okay, this is the land of opportunity, I can do a lot here. And intergenerational cultural conflict, which I'll talk more about, but that's really that conflict between parents and kids, and I have a slide on that. And so in general, like any kind of stress, these things are bad, right? They result for kids in higher externalizing and internalizing behaviors. They're associated with alcohol use, substance use, all types of challenges. I did a paper with Lisa Fortuna looking at Latino immigrant adults both here and in Spain, and we found that having citizenship was associated with reduced suicidal ideation. So again, makes sense, right? You have citizenship, you have a certain status in the country, you have access to services. But interestingly, that was true, across our site. So even in Spain, where culturally and language-wise there weren't as many conflicts, having citizenship still provided a certain level of security, presumably. We couldn't show that exact reason why, but we did know that citizenship was associated with reduction. More than 10 years living in the host country actually was associated with increased suicidal ideation. So there's a little bit of a duality there. Having citizenship was good, but being in the country that long was potentially not. So there's questions that we have there. Discrimination, right? So we know, again, discrimination linked to increased depression, not hard to imagine, right? So among Latinx youth, but also among other groups. We really have this issue, right, of seeing, and it's not, there's some documentation now in the literature, but what's the impact of discrimination and prejudice at a societal level? What's the impact of seeing this constantly in the media, in politics, of having the group that you identify with be talked about in disparaging ways? And what is the impact of that for adolescents who are really in the process of developing their sense of self in relation to the community where they live? So these are some really immediate and urgent questions, right? And then what's the effect of the multiple minority status? So now you're not just a minority in terms of your ethnic affiliation or your race, but there's really all this intersectionality. And so we've got gender, we have race, sexual orientation, gender identity, English language proficiency, documentation status, and disability, and the ways that this impact communities in different ways. And then, as I said, I'd return to intergenerational cultural conflict. And so this is the kind of thing where if you've been in, I think if you've been in a family where there are different cultural orientations between parents and kids, you know what this is like, right? So people, can connect to this often, which is that parents and children are acculturating in different rates and in different ways. And so the experience for an adult of being in the US and the experience of an adolescent is different. And you already have a natural process of conflict and individuation and separation for adolescents, and that already creates challenges in any family. But now you have this added piece about who's associating with what values, who's associating with what traditional practices or non-traditional practices. And so parents often after migrating can really hold on to the home culture more strongly because they're trying to keep it alive. There's some good studies to show that even compared to their peers, that they grew up with in the other country, they may be more conservative or more sort of intense about that process because they really are the ones that are holding on to that in the new context. And youth are really trying to fit in with their immediate environment. So this plays out in different ways for different families. It's not to say this happens for everyone or happens in the same way. But the challenge is that for people where it is an intense source of conflict, it is linked to negative behavioral health outcomes because it amplifies that sense of conflict and lack of communication within a family. So I don't want to completely pathologize it because it's a very normative process and it's something that families can definitely work through. But if it goes too far, sort of like with everything that we see in terms of family conflict, it can be negative. And then also this role reversal, which, if children have more power because they can speak English, they know how to navigate the environment, and the parents don't have that power if they are in a position where they don't speak the language. That's going to be a different experience. Yeah.
So I wonder, what is the distance between the cultures, between the American culture and the Latino culture?
Yeah. I think it can really vary. I mean, it varies, I think, depending on the country that you're from, and it varies depending on where people were raised, even within that country, and sort of what they connect with. So often, in Texas, for example, where I was trained, often I was working with families that were Mexican immigrants and then migrated from rural areas, that were very recent immigrants in case, the parents, and that was very different than parents that had lived there a long time and, were English speaking and were more adapting to the environment. So I think that's part of the question, sort of where on the spectrum do people fit. But I think there are quite a few differences in terms of, certainly language use is one piece that can contribute to that, but then also in terms of sort of values, so values of kind of a collective sort of family-based environment versus more individualistic, is one of the pieces I think that often comes up. And things that are, kind of as basic as how people dress, or how you behave in public, or how you interact with friends, can be a source of conflict, right? Are you allowed to go sleep over at somebody's house? Are you allowed to do these things that are sort of normative in the U.S. Culture for adolescents and are not as much in other countries? So then, within Latinx families specifically, we have this construct of familismo, but I think there's ways that, people can find connection with that across a number of cultures. But it's the idea that there is this cultural value that really emphasizes family closeness. It emphasizes family cooperation and also this deference to elders. And so this can be very positive, in some views, and people can also experience it as limiting, right? So it kind of depends on the person and where you are. But it is considered a multidimensional construct. So it's partially structural, but it's also considered, so who lives in your house, right? Do grandparents live in your house? Do extended family live in your house? But it's also behavioral, and so the idea that, how frequently do you communicate with your parents, how frequently you communicate with other family members, and then attitudinal, so how do you see family? And these are some of the dimensions that have been talked about, how much do you agree with this? So when we're doing like a familism scale, people might talk about, do you think that family needs come before individual needs? Do adults need to stay emotionally close to family? Do they need to stay physically close to family? Those kinds of questions. And so I think what's important is to know that, again, it's not a one-size-fits-all thing. It's not saying, all Latinx people feel this way, but it's more that this is a value that exists within the culture, and families might fall in different parts of the spectrum with that. But it can certainly be a protective factor that can be built on. And again, with adolescents, it can also become challenging, right? If somebody wants to individuate and follow a more individual path, and the family context does not support that. So it's something to be aware of and something to navigate. So in terms of then my project, so this brings me to sort of the key pieces that I've built on to develop my project. So my idea was really to focus on family-based prevention, right? And why? Because every study that you read pretty much on suicide risk, family conflict comes up as a risk factor in any culture, any situation. This is something where higher levels of family conflict are a risk factor, and many studies, including some analyses we're doing now, parent-child communication is a protective factor, a good parent-child relationship. And so we see a lot now in suicide prevention around social connectedness and the importance of that, and so families are where that starts, especially for kids. And then there's been some really great research recently. This was, I think, probably now 2 years ago, but there was a special issue of one of the suicide research journals, and they really did some secondary analyses of family-based prevention programs. And these were programs that were not developed to address suicide. They were either developed, one was substance use, one was for families that were bereaved and grieving the loss of a loved one. There were a few different types of programs, but they got to follow up and look at long-term outcomes. And they had some promising results. Not all of them reduced suicide attempts, but in some cases there was one that did, one that was focused on Latino families and substance use, found that for families that had poor parent-child communication in the beginning, it was very effective for reducing suicide risk. So definitely promising findings for this idea that you can go further upstream. You can do prevention at the family level and it will have an impact. And so that's what I aim to build on. So building on the gaps that I sort of told you about already, which is evidence-based prevention is lacking in general, and then we really don't have things that are geared towards immigrant youth. And we see that more in substance use research, and we just don't see it as much with suicide research. And so the project really focuses on longitudinal data analysis, which I won't talk about as much today. I'm happy to follow up with people about that. But then this other piece, which is the development of an intervention, and I'm working on that now because I'm in year 2 in pilot testing, and looking at ways to reduce family conflict, intergenerational cultural conflict, and then increase the parent-child communication. And so, again, this is a lot on one slide, so I'm not going to get into so much detail, but it's just to let you know that the model I'm looking at in terms of suicide prevention is really integrating a few different areas. So certainly integrating an eco-developmental framework and looking at kids in the context of families and schools and communities and development across the lifespan. But then also the interpersonal psychological theory, which has been a very influential theory that really focuses on the ways in which two interpersonal concepts. One is the feeling that you are alone and you don't have connections and you want to belong but you don't. And the other is the feeling that you're a burden to others. Those two things come together to produce a risk for suicide. And then the thing that pushes it to an attempt or a completed suicide is really this acquired capability. So the idea that someone is then able to move to that point sort of cognitively and behaviorally where they will actually attempt suicide. And the capability piece kind of focuses a little bit on exposure to other life-threatening types of instances. And so for instance, people that have been to war, people that have experienced physical abuse as children, and people that have been exposed to other suicides potentially have that higher risk. And so there's a lot of people working in this area and testing this area. And I really focus on those interpersonal pieces because I think that's important at the individual level, but also, as we mentioned earlier, at the societal level, right? So how do you belong within a larger society? And then this other model, which is Luis Zayas, who I really recommend if you're interested in this area, reading his work, but he really focuses, there's a lot here that I don't have as much time to go into each piece, but what he really focuses on is what are the reasons among the Latina girls, and really you can see that a lot of these have to do with family. It has to do with family, with parent-adolescent relationships, because he found in his research so much impact of that, of the mother-daughter relationship, of the cultural conflict between parents, as well as those being potentially protective factors. So when you get to this point of what I'm hypothesizing for my intervention, to me, I think at this point it doesn't really, it's not rocket science, right? It makes sense. We want to build family resilience. We want to do that through improving communication and reducing conflict. And through that, we think that increases social support, that increases coping skills, and that increases self-regulation. And that reduces risk for suicidality. So it's not to say that this is the only thing you do. It's not to say that individual and biological factors don't play a role, because they do, but those things can fit here. We can strengthen families and create a more supportive environment. And if people need more, if you need psychopharmacological treatment, if you need evidence-based therapy for particular risk factors, for particular diagnoses, anything like that, that can all fit into this. There's nothing that says we can't do the family-based strengthening first and then figure out what else do we connect people to. And so that's the premise. And then within all of this, what's not here is sort of the background of culture, right, and of experience. And so my intervention development process, I'm mindful of the time, so I can go through some of this relatively quickly, but the important thing here is really that it's a collaborative process. So using something called intervention mapping to really map out what are the risk factors we're targeting, what are the pieces that we're building in that are evidence-based, and then how do we then collaborate with families to review that material, to look at what we're doing, to do focus groups, and to really develop the program. And then how do we prepare for a pilot, to really piloting the intervention, and how does that information get fed back into developing the intervention. And so again, our proposed sessions, for anyone that does family-based therapy, this in particular doesn't have a lot of specifics to it. So you'll see later the issues I'm grappling with are a lot more specific than this. This is kind of an approach that makes sense from a family-based treatment standpoint. You bring people together, you develop a definition of the problem that's really more about the family and not about the individual. And you work on some of these areas, family cohesion, communication, and then intergenerational cultural conflict, which is one of the key pieces, and then how do you solidify those treatment gains so that this continues on into the future. So with all of that, that is where I started, right? So that's sort of the focus of my grant and what I decided I would do and I would develop. But what are some new considerations? This was something I really wanted to talk about today because I think that you got the grant and you have this project ahead of you, but the world changes and life changes, and there are new considerations that come up and really cause you to think about what's the best focus. And so for me, some of these have been working on some projects around the mental health of unaccompanied immigrant minors, which I'll talk about, the impact of the current socio-political climate. So I received this grant in, I wrote this grant in 2016 and I received it in 2017, so you can imagine what that context has been since then. And what are the stressors and needs actually for Puerto Ricans post-Hurricane Maria, which we're now just past the 1-year anniversary of. So what does that mean? So unaccompanied immigrant minors, these are kids that migrated into the US and crossed a border by themselves. Not necessarily by themselves, and they might have been in a group and with other people, but they weren't with a parent or guardian. And in many cases, they do reunify with other family members once they're here, but the idea is that that process was undertaken, in some ways alone. Often through other groups that are migrating, often through a coyote that is paid to bring them across the border, but they're not with a parent when it happens. And so what does that mean? I mean, these are kids that are already at risk. They've been separated from their parents in most cases for some amount of time. The parents have migrated first. And so studies really find these high rates of trauma, and not just, not just any trauma, right? Really severe sort of traumatic impact, both in the home sometimes, so we see these kind of 22%, a fourth of them in these studies at the border reporting abuse at home or by caregivers or in environments sometimes where they haven't been protected by being with a direct parent or caregiver. And then also these really intense experiences of sort of crime, organized crime, of gang violence that are happening in the countries that they're coming from. And so, in Latin America, they're coming from Guatemala, from Honduras, from El Salvador, so these are kids that are coming from areas that are really experiencing quite a lot of conflict. And so we know, now, again, this has become sort of common knowledge, right, which is the science around separation from families, and we've seen a lot of emphasis on getting that science out there, but we know that this is hugely disruptive, forming attachments, and it really impacts in many ways. And before this, there have been prior studies looking at that, accompanied minors versus unaccompanied, and you really see that if there had been that separation with the family, there's a higher risk. So we did a chart review recently, a collaboration with a clinical social worker named Ada Gunning, who was really seeing a lot of these kids in school-based mental health. And so in our group, which was 32 kids that were randomly selected from the caseload, and these are kids that are mental health referred, right? So somebody identified them as a kid in need of services, but this was just the initial evaluation. This is the first thing they met her and what they disclosed. And we found 90% reporting a history of trauma, even though we know that many of them did not disclose the extent of their traumatic experiences in that first interview, and there's many things she found out later, but just in that initial evaluation, we heard about trauma. So 90%, 41% that reported either in the past or currently self-injury, suicidal ideation, suicide attempt. So a very high-risk population, and they were just being seen at school, right? So luckily there were these services, and then they were really able to engage in services at school and had really good outcomes in terms of the number of sessions attended. But this is a very high-risk population, and the reason I think this is important is because when we think of the sort of healthy immigrant, we're not necessarily thinking about everyone in that category. So this is clearly a group of kids that has had to deal with a high level of adversity, and in many cases show incredible resilience as well. But this is certainly not the same experience as the kids that were able to come with their parents in sort of an organized fashion with the goal of moving to the US. This was a very different experience for these kids, and they're grappling with a lot at a very young age. How about the socio-political climate, right? So the studies are starting to come out about that now, right? So we see these increased emotional and behavioral problems among immigrant students in schools, increased psychological distress in Latinx parents that are not citizens. These are recent studies. Decreased ability to engage families in the needed health services. And so I'm hearing from this in focus groups from parents, even for organizations that served immigrants for a long time, the parents felt very comfortable, and now parents are saying, wow, but do I know, really? Do I know? I mean, is it worth it for me to engage in a service when the risk is so high? And so more and more you're seeing parents remove themselves from these formal advocacy care. There was a study that was just released, I think, about New York and premature births among Latinx women starting in 2017, and an increase in premature births, which is a sign of increased stress among immigrant women. So a lot of huge concerning trends, and also limited resources, limited research data to answer them. We have very few databases that really tell us what's going on with immigrant youth, that really separate out who's immigrant, who's not, who's second generation, who's not, and also very good reasons not to collect that data, right, which is unfortunate. But luckily I was pulled into a collaboration with a great group of people at Johns Hopkins, and that's one of the things that we're trying to address. This is Holly Wilcox's grant. It's a pilot grant, and we're really looking at both secondary data analysis from what we have, but also how can we engage parents and youth in these discussions and really make this link to suicide prevention, and establish groups of people to come together and talk about this, because I don't think we'll, no one person's going to solve any of these questions. So that's one piece. I'm just taking the time. And then finally, Puerto Rico. So again, as I said, I'm Puerto Rican. This was devastating, right? And it was not expected. And there's many things to say about that, and there's certainly many things to say about what happens when, on a personal level, you have impacts that influence the course of your research, but also influence just your ability to do your work, because there's so many other things to be concerned about that are more immediate. But what I will focus on now is just this idea of risk. And again, this is not to take away from the incredible resilience that people have shown. But what we do worry about, right, is this long-term risk for kids, because it's not just the hurricane, but it's the effects after, and the lack of infrastructure and support for children. So you see a higher risk of domestic violence and child abuse, because in already stressed situations, people that do work in disaster areas talk about that, the risk goes up. There's less ability to report, there's less ability to leave, and the reports, are that, right, from people that are on the ground and are working in these areas. This experience of ambiguous loss, which is true also for unaccompanied minors, it's just, that's, you lose something and somebody, but it's not definite. There's not a grieving process. It's, some people move, some people stay behind. Pets may have been left behind. There's moving back and forth. You're staying with relatives. You don't know when you'll go home. Homes are in disrepair. Schools are closing, which is another huge piece. And so kids' normal routines are disrupted. Kids that are in living in poverty situations and may have lack of access to healthy food, safe housing. The financial situation is precarious. I mean, it's overwhelming to even talk about, right? But you have these huge disparities potentially, and then you have a system that's already depleted and struggling. What you have in Puerto Rico that's amazing is really the amount of people and nonprofit organizations that really came together to fill these gaps, right? And so really heroic efforts, just day to day by people on the ground that are doing this work. And they are concerned about suicide prevention. There's been a lot of effort to get the crisis hotline out to people. There have been increases in calls. There's a lot of concern about it, but talking to people recently, what they've said is, we'd love to do more family-based prevention. We need this, families need this, it's really important. But who's gonna do it? We don't have clinicians to do it. Everybody's working so hard, everybody's overstressed, people have left. So we really need things that we can do in organizations, things we can do informally, right? And so that's a lot. But I guess what I will leave you with then, or what we can discuss, is this idea that there's so many unanswered questions, and there's things that you have to address step by step. And so for me, there's a lot of questions, as you can see here. There's questions about, how much do you adapt culturally to a specific group, right? To your question, how much do you focus on what's the experience for Latinx youth, and how much do you look for those common factors, which is across immigrant populations, so that we can address all of our populations that are sharing have some shared issues, and also some that are not at all. How do you address gender differences? We know there are these gender differences in suicide risk. How much do you integrate that? How do you integrate this trauma-informed perspective? We see this evidence of very high trauma for immigrant populations and also for migrant populations in Puerto Rico. And these are ongoing and unresolved traumas. And how much do you look at content-specific issues? So for me now, intervening with a family in which their parents recently migrated, and there's an undocumented dad, and there's a certain number of things going on, is very different from intervening with a family that just moved from Puerto Rico after the hurricane, right? Completely different issues potentially. How about Latinx youth that are LGBTQ, right? So I have a few kids that I work with that really talk, there's different experiences, one from a very supportive family and one from a family that's not, and how do you address that in a family-based intervention? Because we know, again, that there's this very high risk for kids that identify as gay and lesbian, and an even higher risk for kids that identify as transgender, and we really need to address that and address that within our communities as well in terms of addressing stigma and discrimination that happens even within families. And then this intervention format piece, clinicians versus non-clinicians, and what are the ethics of doing this work, which is something that I think about often, talk a lot about often, but there's no easy answers to that question. And so with that, I think I will leave this up here because the next slide is just discussion. So I guess first I can take questions, but also I'd just love for people to give their input or reactions to any of this.
Thank you. I think this is really a very useful session. I guess I wonder some of the thinking or models that have been considered for informal interventions. What can folks do when clinicians are not available or the need is so high that you can't be there?
Yeah.
That are ethical evidence-based.
Right. So I think there's some great models. I mean, I think one of the areas to really look to is Vikram Patel and other people working with the World Health Organization that have really, Vikram Patel. So these models in settings that are lower resourced in terms of mental health professionals, where they're really looking at how do you train non-clinicians, to be in these sort of community health worker capacities that can really deliver mental health interventions. And I think often there's almost sometimes better research coming out of those settings because people have sort of, they can accept, okay, there's X number of psychiatrists or psychologists, versus I think in our field we have more pushback because those of us that are trained as clinicians, it's hard for people to accept that, somebody else may do the job, right, that you trained to do. But the reality is that there's not enough of us, there's not enough psychologists, there's not enough psychiatrists. And so my view of it is not, so, and this is not a unique view, I think this is where, people are in a lot of this research, is that it's not about replacing, someone entirely, but it is about how do you have people, what are the pieces you can step down that can be done, and how do you supervise that work? How do you provide appropriate supervision and clinical training? And I think in so many settings, people are doing that anyway, I think is the other piece, right? So if you're a teacher, if you're somebody that's a non-clinician that works in a school, like you're already providing mental health services left and right to kids, right? And often without supervision or supporting how you do that. And so really just providing formal models where you can do that. I think with the family-based piece, it is thinking about what are these family strengthening aspects that can be done without having necessarily a strong clinical focus, and then what's the supervision and oversight so that when there is a clinical concern, that can also go to the right people. So I'm certainly not about, removing clinicians entirely. I think we have very important training, to bring to the table, but I think there's a lot too that we do that can be done well by others.
So it's very informative and interesting to hear this. I had just a few questions and maybe ideas. I was thinking of, when you mentioned this group, I was thinking about the age and age at which the intervention is planned, and what if it is started much earlier than the age at which we start seeing trouble in the children in terms of both the boys and girls. And because we're talking about the immigrant population, have there been experiences of when the local host communities have been involved in interventions? And because you spoke about their culturation stress and then, sort of also adjusting to the culture in the US,
right?
Taking pieces of the culture in the US and incorporating that. So how have there been interventions where the community, which is sort of the host community, they have been involved in interventions? And what about aspects of social justice? Because a lot of what you're presenting seems to be the result of the inequities and inequality that they are experiencing. So treating that as a mental health issue versus the social justice aspects, and how much does that help them when they see the agency in their own selves, as opposed to just being seen as somebody that needs.
Right, that there's a...
So just these three.
Yes, those are great questions. I'm going to try to answer each of them. So I think the first one was about the age. And so the age that I chose, which is still, subject to change based on our focus group findings, but right now I'm looking at sort of the 12 to 15-year-old range, because it's that early adolescence, transition into adolescence, and because rates of suicidal ideation and attempts really peak around age 15, they start going up more. But yes, the question of younger kids is really important. There's people doing some very important work in identifying suicide risk among younger kids, so the numbers are lower, but it's extremely concerning, and there are some disparities that have been found in that. And I actually have a colleague that is interested in developing family-based interventions for younger children. So that's definitely an important area. And I think in some of these papers that I talked about where they looked at the impact of family-based prevention, I think some of them were younger. And Holly Wilcox also has some papers on something called the Good Behavior Game, which was a school-based intervention that was delivered in 1st and 2nd grade, and then finding these long-term effects. And I think the key piece to remember about that is I think sometimes people say, well, how's that possible? How can you do something at this age and it still has an effect? But really it's that it's a cascading effect, right? So you do something in a family that changes family interactions potentially, and it may be a small thing, but that can have really long-term impacts potentially. So I think that's very important. And then in terms of community involvement and social justice, so I agree with you. I presented in Puerto Rico recently, and that was exactly what I talked about with regards to family prevention, which is that you can't then think of it as families are the problem, right? So really the bigger context of this is thinking about what are the contexts we have, how do they support or not support families? Because when you're talking with families about spending more time together, right, can they? Do they have the time, or are they working, 2 or 3 jobs? And what are the stressors that impact on that? And so you really, I agree with you that I don't think you can address this without addressing the larger context. And there is a fine line where I think as clinicians, on the one hand, well, this is a thing I can do, right? I can intervene with individual families. On the other hand, am I creating an expectation that then families cope with, with unjust circumstances, right? And it's the same with any of our interventions to cope with discrimination, for example. Well, are we teaching people to cope with something that's not okay? And so I think having that balance, we need to, exist and progress and thrive in our own individual circumstances, but at the same time thinking about what's the larger policy implications, I think is very important. And I think getting people to understand what the impacts of these things are on families is important.
Hi, thank you for your presentation. I have a quick question. Earlier in your presentation, you mentioned that second generation immigrant children were more likely to engage in suicidal ideation or suicide-related behaviors. Do you have any guesses as to why that might be when comparing second and first generation children?
Yeah, there's this idea, the mental health literature, not an idea, it's an area that's been shown a lot in epidemiological studies, which is the immigrant paradox, and this idea that immigrants are often coming from more adverse circumstances, perhaps greater poverty, more stressors, but somehow are healthier on certain dimensions than people that were born and raised in the U.S. And mental health is one of those areas where we find this sort of healthier experience. And so I think there's different reasons for different mental health issues. For suicidal ideation, yeah, it's interesting. I don't know that it's been definitively shown, but I think what people really think about is the idea that maybe when you migrate from the country, maybe that intergenerational cultural conflict it's not there, right? There's more of an affiliation between the parent and the child. There's an ability to speak in the same language versus families where the child was born in the US and the parent was born somewhere else really have greater cultural distance and also language distance. That can be difficult for parents to discuss more complex topics. Because they really are more comfortable in 2 different languages in some cases, and then also that the particular stressors, of being, that potentially when you come from another country, you have this understanding of yourself as being from somewhere else, and you kind of deal with some of the exclusion and things in that context, versus you were born here and you're still having that experience, potentially more damaging. But yeah.
Thank you.
So thanks for your talk. I'm curious about learning more about 2 things. One, I'd like to know more about the intervention format or areas of inquiry there. You had mentioned that there was a review of other family-based interventions with other topics like substance abuse. So curious about that. But then also, what, metrics would there be for success? So just kind of I'm curious about your thinking on that.
What I'm thinking about in terms of that.
please.
Absolutely, so an intervention format, I think there's definitely, so Familias Unidas, which is one of the programs that was for substance use that they did do that, assessment of, and that is part of what I, look to as one of the models. They're a multifamily group program, so that was for substance use, but the idea was really bringing Latino immigrant families together and really having families together work through these issues of sort of cultural values and shared cultural strengths and communication and things like that. So sometimes, thinking about group formats versus individuals was sort of one question. And then in terms of, I think, with this idea of parent peers or of kind of paraprofessionals or community health workers are probably the 2 areas that people really are thinking a lot about and developing, and different programs do this in different ways, but I think that's, across a lot of areas of mental health, there's definitely people doing And I think the difference between that would be, is it that you get parents that have had a shared experience or have kids, around the same age and sort of train them to deliver certain intervention messages, or do you have people that you hire that are from within the community? Maybe they're parents, maybe they're not, but it's their job, right? And they're going out and doing community health work. And I think we have some great models for that, not just in mental health, but in things like cancer screening and prevention. And there's a lot of areas to look at for that. And you mentioned outcomes. Sorry, I just realized there's another part to that question. So I'm looking at the, it's a pilot study, it's short term. I'm looking at the intermediate outcomes of the improvement in communication, reduction in conflict, looking at both self-report, but from the parent and child perspective, as well as family observation and clinician sort of report. And then definitely looking at reduction in suicidal ideation and attempts, but because it's such a low base rate behavior, and you really expect that would take longer to see. That's one of the challenges with prevention, is the results are usually seen further down the line, but you still want to measure it. Okay, sorry.
Oh no, it was, I was going to ask the
That's
second
okay.
part.
Yeah, and I guess the other part to mention that I think some people are doing great work in this now, and I think there's some funded grants now to do this, is because it's a low base rate behavior, it's hard to see if our interventions have an impact because you don't have the numbers. So they're really looking more at integrative data analysis and taking studies that have already been done, putting them in a big data set, looking at, what are the results. Maybe if we get more together, then we can see that. And part of that is also designing our studies in a way that they can do that long term, right? That we're all using the same outcomes and then can combine them with other results.
I'm curious about the first point, the cultural adaptation versus common factors one. What do you think are some disadvantages to cultural adaptation or intervention?
Yeah, I think one of the major disadvantages is how do you do it for every group that you work with, right? And so I think, when doing my training in Texas, as we both did, right, you could have a Latinx specific intervention and be in settings that we're treating primarily, a large portion of the population was Latinx, and you could really train people in that, and that was a specialty area that people wanted and needed to develop, versus in Boston, seeing, immigrant families from all over, right? So at one point during my postdoc, I was just seeing, 4 families, and they were from, 4 different parts of the world, not even 4 different countries. That's the biggest problem, I think. I love cultural adaptation, and I think the more that we could have things be congruent with people's actual life experiences, the better. But it's very challenging to do that, and then we know that within our broader groups, there's so much heterogeneity in our nationalities and what those cultural pieces are. So I think that's probably the biggest challenge, and the reason to have something where you can at least know that there's a general framework, that then you can train people in and that they can use. I don't know if you have anything to say about that, because I think there's something a lot about that area.
Right, and actually, just even to your point, I was thinking about cultural adaptation, even with your 3 different populations that you listed, like how different you have to adapt for the families that are experiencing a lot of migration-related traumas versus the families in Puerto Rico,
Right.
And the traumas there. And I don't know if Aurora has any thoughts, but yeah, that is always a challenge, and we find that, regardless of the group. And we talk about this a lot as colleagues about the adaptation process of how, oftentimes when we're talking about funded research or research process in general, we're talking about bigger reach. And we're trying to do bigger reach. People don't want to know which groups are getting, specific adaptations and work for it.
Right.
They want to know this will be applicable to everybody. And so that's a tension that I think is ongoing, like you said.
Yeah, it's really interesting because then in the field, in medicine at large, we have this kind of idea of precision medicine and how do we get treatments that are targeted to really specific individuals, and can we have a medication that targets this X thing that's unique? And then at the same time, we have this challenge within mental health where people say, well, why don't you do something that applies to everyone, right? And sometimes people's conceptions of who everyone is, are very exclusive of the groups that, we're working with, which is also interesting. And so I think a question of how do you really get to an everyone where there are things that can be adapted in different ways.
I think the only thing I would add to that is that there's a big focus on not, as we were saying, as everybody was saying, not adapting things to different cultures, so not having 10 different types of interventions. At the same time, we don't really know what the common factors are.
Right.
Or rather, and when we do think we know what the common factors are, it's a theoretical common factor that was essentially a theory developed for certain groups of people. So how can we say that's a common factor, common to whom?
Right.
So it's a really hard discussion, and I think it's a lot of it is selling this to people that are in charge.
Yeah, and I think, and how families experience it, right? So I think it's absolutely true. I mean, I think what experience I had with working with family, was around this. There was a lot of what I could see with this intergenerational cultural conflict, and it was very extreme. The daughter was very artistic and very, independent, and she really wanted to dress a certain way and express herself a certain way and participate in certain things at school. And the mom was very traditional and really saw that in a negative light. It created a lot of arguments and conflict. But when I brought that to them, this question of like the different cultures, well then, immediately they said, the mom said, well, wait a minute, there's so many things I love about American culture, that's why I live here. And the daughter said, well, I love, my home culture, this is so important to me and my family. And so that was important because it was sort of by naming it, then they could sort of decide not to associate themselves with that and really show more of that context. And so it is really important that these are sort of questions to ask and things to be aware of, but it's not to say that they happen in this specific way for every family. And that you don't always know, what the context is. So you can't go in with a setting of, oh, this is exactly what's happening here, now I know. And similarly, you might go into settings, we have a group of kids where, you would expect that they'd be talking a lot about discrimination, and that's not what they were talking about. They talked a lot about the sources of support and the ways that they experience that in their environment. And so, that's very important. It has to be person-centered and family-centered. But you also have to know what domains to consider, right, to look into, which that's the problem that on the other hand, we have a lot of clinicians that don't, right, that don't ask about these contextual factors and don't ask about discrimination, don't ask about their experiences.
That's very interesting. That is, we're just talking about what a good idea that is. Maybe, ultimately, even in some of the work that we do, it's about asking about domains. It's about addressing domains, and then it becomes individualized to each family, and I think ultimately, I think there is that tension between manualized treatment, which has protocols and specific weeks when you focus on X, Y, and Z. And then just, I think, traditional psychotherapy, which is more free association, what comes with that. And I think when we're working with children and families, sometimes you have to balance. Especially with families, you have to kind of balance the two. Absolutely. But then that makes me, to even bring up more questions that we don't have time for. It makes me think about that, the discussion around who is delivering the intervention. Because if we're talking about how much training, I appreciate how you mentioned in our field, we're actually more averse to thinking that paraprofessionals can deliver our interventions because we spend so many years of our lives training, before we're able to. But there is such great work being done with paraprofessionals or community-based lay workers who are delivering interventions, and even teachers and that whole aspect.
Yeah, we have these parent partner programs, especially with early childhood. Well, there's a lot of ways to think about it. I think the other thing I was going to mention, because we were talking about the immigrant families and questions to ask, so Celia Falikov wrote about the Latino families in therapy, but it's really a wonderful read for anyone interested in immigrant families and immigration, because she really writes about these challenges and these issues and sort of the transnational families and how you organize family therapy. And so her framework is multi-systemic, ecological, cultural framework. So she really talks about what are the domains. So it's really about the overall framework and how do you look at those domains and then work with families individually within that. And the idea that families are unique, right? And they're unique within those contexts. And her updated version has some good chapters on technology, for example, and how that's impacted families. So I think that definitely for someone who's more interested in family therapy and the really getting into that piece, it's a really great approach.
Thank you.
Thank you.
Okay, so I know we're out of time, but I just wanted to do a quick announcement. So this is actually perfect. We our talk on parenting interventions is leading me right into the my class that I mentioned last time on working with children and families from evidence-based methods is now online. So as you're looking for courses to take, it is open to everybody in the college, Mondays at 11. So look for me, look for my name, it's under counseling psychology, so CCPJ. Another announcement, our next brown bag will be Dr. Prerna Aurora, right here in front from school psychology here at TC. So we're looking forward to that. And that's, Emily, do you have the date for that? I can't remember the specific date. We will send out an announcement because that escapes me currently. It is usually the third Tuesday at 3. And last thing is there might actually look for an email soon about an opportunity. I have some openings in the lab for some very specific needs. And so for those of you looking for research opportunities, that will be going out. And then of course, as we're collecting more research opportunities, we'll also send that out on the list. All right, thank you so much and hope to see you next time.